Okay. Hi, I'm Mary-Ann Sontag, and
I'm Laurie Minns.
we are here today to talk about the brain and glioblastoma.
Yeah.
Right?
And
Yeah.
different regions of the brain that are affected by it. So I teach human anatomy and physiology.
That's very convenient. Here at the University of Montana, I teach in the School of Social Work, and my specialty is end of life, palliative care, grief and loss, uplifting, things like that.
Right.
So, when I was working as a hospice social worker, one of the patients that I had, I remember them. I remember their name. I remember their house. I went over to do the intake with the nurse for hospice, and the story was that they discovered this glioblastoma for this woman because she started doing very odd things, like she cooked enough spare ribs for 30 people when there was only 2 of them. And that was sort of a clue to the family that something is not right.
Right.
But not everybody who has glioblastoma cooks an excessive amount of spare ribs.
Right. So when my husband was, the symptom that brought him in to the ER was that he had a lot of difficulty naming words.
Like he could look at the word and not...
He couldn't read anymore, so he lost all of his language reading capacity.
Yeah.
He describes being in the toothpaste aisle at the local grocery store trying to buy the toothpaste that we always buy at home, and he could not read any of the names.
Wow.
And so then when he tried to contact me to bring him to the ER, he texted me, and none of his texts made sense. But he did manage to get help, need help, ER. And so I had to figure out where he was and then bring him to the ER. I thought he was having a stroke.
And did that just happen like that?
So apparently he had had some symptoms prior. He'd had some difficulty reading before this, but he just chalked it up to something else. Like, oh, maybe I was really hungry, or maybe I was dehydrated.
Mm-hmm. Sure.
You know, the more common symptoms.
Yeah, right.
Or fatigued, or...
Right, because normally you don't I don't really know what that word is. I must have a brain tumor.
Right, no, it wasn't like that. So it turns out, and I've heard of patients diagnosed with glioblastoma after being in a car accident.
Really?
Yeah, because their judgment got really bad, and then they lost some peripheral vision, things like that.
And so why are the symptoms all different? Can you explain that to us?
So that is the focus of our session today. So these are our brains.
Well, they're not our personal brains.
No, these are plastic brains. And I think what's really important is that we recognize that these brains make up, mine's a little more complex, so things come out.
I have a simple brain.
She has a complex brain, but it's not quite, yes, I'm just working here on the cerebellum. There we go. So our brains, right, are enclosed within our skull, and they don't have anywhere to go. Like if there's an injury to the brain or the brain starts to swell, it's still stuck within this space, and that's going to have some implications.
Yeah, because if the brain is swelling into the skull, isn't that going to cause more damage to the brain?
Right, to other parts. It can sometimes just temporarily impact function. So a lot of times with the glioblastoma tumors, you have a tumor that's growing and it's just pushing the healthy parts of the brain up against the skull, and it's causing things like headaches, fatigue, seizures are really a common presenting symptom for patients with glioblastoma.
Okay.
But then there are other nuances, and they have to do with the regions of the brain that are impacted. So, if we look at the brain here, this is the front portion or the anterior portion, and then back here is our posterior portion. This front portion, these lobes here are known as your frontal lobes. And then in the back we have the occipital lobes. Those are for vision. And then...
Do they really look different like this?
This is the cerebellum back here, that part that you're holding on to. This part we'll see, I'll go through a little presentation a little bit later, is important for coordinated muscle movements, so fluid movement. So if somebody presents with a cerebellar tumor, sometimes one of the clinical tests they'll do is have them try to touch their nose with their finger. It's kind of like a sobriety test. But somebody who has a cerebellar tumor, as they get close, they'll lose the fluidity of the movement.
Oh, interesting.
And if it's on the left side because of the lateralization, the hemispheres, if they have difficulty with the right side of the body, but the left side is fine, then that's telling you that the tumor is going to be on the left side of the brain.
Interesting.
Before any imaging. That's not the only thing, there are other.
Cause it.
Right. There can be some other things. But there are other really regions that will give rise to really specific symptoms. So my husband's naming symptoms, those are because it impacted his left temporal, parietal regions, and those are really important for language.
Okay.
So we'll go, as we kind of continue on through our discussion, I'll be able to perhaps provide some insight into why these tumors grow so fast, why they are called glioblastoma multiforme, and implications to different functional and cognitive and emotional and regulation capacities associated with the patient.
Based on where in the brain that tumor is, what other healthy tissue it's impacting, and then I think we just have to mention again that we're going to talk about that radiation can damage healthy brain tissue and cause symptoms.
Absolutely.
Okay. All right. And so you're going to give us a PowerPoint presentation on the brain.
A lecture.
Lecture.
But so I think before we can even think about major brain regions associated with glioblastoma, we need to think about what is glioblastoma. So glioblastoma really is an overgrowth of some glial cells. That's why it's called glioblastoma. And they have a special name. They're called astrocytes, and they're shown up here in green. Those astrocytes are special support cells that help neurons. The neurons are shown in brown. And these astrocytes they're star-shaped. That's why they're called astrocytes. And they have these arms that kind of extend out and grab onto blood capillaries, and they help maintain what we call as the blood-brain barrier. They also help to anchor neurons within the tissue.
Okay.
And they do a lot of, they're kind of like, a neuron's best friend. They provide a lot of support. They help with different kinds of chemicals that keep neurons happy. They take up space if for some reason neurons are dying, just to maintain the structural integrity of the brain. And when these cells, which astrocytes typically divide, neurons don't usually divide. And so when these cells start to divide in an unregulated fashion, then they become cancerous. And these are the cells that are really playing a role in the development of the glioblastoma. Astrocytes outnumber our neurons about 10 to 1.
Okay, interesting.
And together, these make up what we call is the gray matter regions of the brain, which is one of the reasons why gray is kind of a color in support of brain tumors. Now, when somebody develops a glioblastoma multiforme, it's called glioblastoma multiforme because once these astrocytes start to divide in a dysregulated fashion, they increase the growth of the blood capillaries. So when somebody's doing a biopsy, for example, when a neurosurgeon is checking to see what the tumor type is, they'll typically find, strangely looking astrocyte cells that are dividing really rapidly. They'll find blood vessels, like a much higher amount of blood vessels than they normally would in a region of healthy brain. And then all of that activity means that they're taking up increasing amounts of space. And when they do that, it's going to starve other healthy cells from the important nutrition that's provided by the blood. And they die in a form known as necrosis.
Okay.
And so they'll find necrotic tissue in that. So that's why it's called glioblastoma multiforme.
But typically when people are diagnosed with this, is it just in one spot?
Not necessarily.
Okay.
So it's probably more common to have a single area of tumor, but it's not unusual to find multiple regions of the brain that have there are multiple tumors.
Okay.
And sometimes with the primary diagnosis, there'll be a single tumor, and then later when it recurs, it'll come up in different spots of the brain. What used to be like the neuron's best friend has now become the major frenemy in the brain. That's a terrible way to
That's actually
terrible analogy.
That makes sense. But
So-
so let me just ask you, if the astrocytes in one part of the brain are being a terrible frenemy, does that mean that the astrocytes in other parts of the brain are as well, or is it possible that the other parts of the brain have neurons and astrocytes that are happily coexisting?
So I don't think that anybody really knows the answer to that.
Okay.
There are a lot of molecular switches that turn our favorite astrocytes into our frenemies. And those are being studied and characterized more and more now than they ever have before. But there may, and we don't even know what causes glioblastoma. There have been some more recent genes that have been implicated as being mutated, leading to dysregulated cell growth. But there's not a clear-cut answer, which is why we still don't have a cure for it.
Yeah.
Okay, so imagine now these astrocytes and other glial cells that I didn't talk about and our neurons. These guys are all making up the 3D structure associated with our brain. When a patient and their caregiver go in to have a consult with the neurologist, or if you're lucky enough to have a neuro-oncologist, then they're going to start talking about what part of the brain, the location in the brain where the tumor has been found. And if we just do a really basic anatomy of the brain, there are these, canyons that separate the outcroppings of the brain. So the outcroppings are called gyri, or a single gyrus. And then the canyons, so the internal portions of those grooves, are known as sulci or a sulcus. And these delineate different lobes associated with the brain. And so you can see those are highlighted here in this presentation. And then now that you kind of have these landmarks of these specific sulci that are going to delineate different regions, now you can see that we can look at the frontal lobe. So the frontal lobe is going to be, right behind your forehead. Okay. And the occipital lobe is going to be right at the back of your head. And then inferior to that is the cerebellum. And this region, which is really on the lateral parts of your brain, those are the temporal lobes. And then between the temporal lobes and then right between the frontal and the occipital lobes, that part, those are known as the parietal lobes. And so we have left and right versions of those lobes. The right hemisphere of the brain controls the left side of the body, and then the left hemisphere controls the right side of the body. So that has implications if a tumor is located, say, in a left temporal lobe, then that's going to have implications maybe for some motor movement on the right side of the body.
And so knowing this is important because it gives us a sense of why are people with this tumor having different kinds of symptoms.
Oh, absolutely.
It depends on where in the brain it's located.
Yeah, this kind of core region that's going to give rise to the spinal cord, that's where the brainstem is. And the brainstem is really important in controlling what we call our autonomic functions. So regulation of heart rate, respiratory rate, the things that just keep a human alive.
Keep humming along.
Right, and so anything that's going to lead to expansion of the brain tissue, or if there's a tumor in that area, then you would be, there could be cardiac-related death or respiratory-related death as a result of the location of the tumor.
And do glioblastomas sometimes occur in a brainstem area?
They do. They can occur anywhere within what we call the central nervous system, and that's the brain and spinal cord. Spinal cord lesions are very rare, and that's because glioblastoma is made of glial cells that really only like to exist within the brain region. But there have been reports of them moving into the spinal cord. Like a central nervous system type of metastasis is what we call that. Yeah, unfortunately.
Yeah.
Okay, so then this is another view that really shows on the left side of the screen, a normal brain. This is the axial view, so this is where they're taking cuts from like the top of the head down.
Looking down.
Mm-hmm. And so each slice is going to come across like
Uh-huh.
this. And one of the things that you always look for in like healthy brain is that you have symmetry between the left and the right side. And then you also have the location of the ventricles, which are fluid-filled areas within the brain, and that they're even. Sometimes in a case with often is the case with a glioblastoma, and you can see here, this is a clinical picture of a glioblastoma, that those dark fluid-filled spaces, those ventricles, get squished.
Yeah.
And then the whole brain shifts because everything is still enclosed within the skull. And so that can lead to other global problems in the brain. And sometimes that's referred to as mass effect, because you have just this group of growing cells that are pushing out into that area. And so one of the things that's also done for glioblastoma patients is that they're commonly prescribed dexamethasone, which is a corticosteroid, and that helps reduce this kind of edema. And so that really can be important for reducing the swelling in the brain so that other structures aren't so affected. In the frontal lobe, that really controls a person's intellect, their judgment, their planning, their ability to make decisions. And so for your friend who made way too much food for 2 people, that may have, it could be that patient's function was impaired in that area. And that can be due to the location of the tumor. It can also be due to, global effects of having the tumor maybe squishing onto those regions, because the whole brain, right, is enclosed within the skull. So although there are pretty well-defined regions that are associated with dedicated kinds of actions and behavior, you can also have global effects too.
Okay. So while the tumor may not be located in that region, the region's impacted literally by getting pushed.
It could be by getting pushed. Also, remember we talked about radiation and the margins where the radiation goes. So if that radiation, based on the location of the patient's tumor, is kind of close to some of those executive functioning regions of the brain, then that would have an impact as well. Yeah.
Yeah.
Other places, there are some internal structures that are going to play a role. There are definitely regions that are associated with sensation and movement. So as we move into the parietal lobe, for example, that also has impacts on cognitive functioning and intelligence. Sometimes you can see really specific kinds of symptoms, like not being able to tell the right side from the left side. As we move into the occipital lobe, that really is dedicated to vision as well as perception of what you're seeing. So that can have some very specific implications in terms of blindness, where the eyes are working fine, but that region of the brain is not working great.
There's so many different symptoms that could be pointing to this tumor.
Oh, absolutely. This is a rare cancer.
Unless it happens to you, in which case it's
100% your experience. And then the last area is the temporal lobe. And the temporal lobes, particularly, if these are really important for language understanding. There are some motor regions in here that help allow for formation of words. And so if the temporal lobe is implicated, then you can have some pretty significant effects as well. And remember, the caveat for this is functional brain regions have been mapped out primarily on right-handed individuals, right-hand dominant. And so for somebody who's left-hand dominant or who's ambidextrous, these regions may not apply so much. So for right-handed people, you have your language centers are pretty much exclusively in your left hemisphere. But for left-handed individuals and ambidextrous individuals, they're bilateral. Because we're all different.
Interesting.
Okay. So first we have headaches, and then we have seizures. Then memory loss is pretty common. That can be due to the tumor itself. It also is a common side effect of radiation therapy. So that's something that may get worse over time. There can also be depression, mood swings. So those of us who live with people who have glioblastoma are probably the biggest experts in this area. So sometimes things that you don't think will be triggers for your loved one tend to be. And so you can start to see other personality changes. cognitive changes. Maybe they're having a difficult time telling time or understanding the passage of time. Maybe they just started to get really bad at doing math. Other neuropsychiatric symptoms. So I have depression in here as kind of its separate thing, but then there can be other larger neuropsychiatric symptoms. So a patient could evolve into having severe anxiety or becoming paranoid.
It's almost like you're talking about dementia.
There's a lot of crossover with glioblastoma symptoms and dementia. Because when somebody has dementia-like symptoms, you lose bits of that person. They may have really great long-term memory, but they don't have good short-term memory.
And emotional regulation can be disrupted as
You can
well.
have disrupted emotional regulation, and then also lack of insight is another important symptom that I don't have on this list. But that means that the patient isn't even aware of their issues. And that's common for both physical issues as well as cognitive, emotional. I can't tell you how many spouses of patients who've been bedbound, in their last weeks of life insist that they can walk. They just believe they can walk, and they don't understand why nobody's letting them walk because they're a huge fall risk, and the loved one doesn't want their patient to get hurt even more. So that is probably one of the most challenging issues.
And I guess that shouldn't be a surprise. I mean, this is a brain issue. So of course there's going to be cognitive and psychological, intellectual changes, memory change. I mean, it shouldn't be a surprise, but it's not like another kind of cancer or tumor where it just affects perhaps that area. This affects everything. This is like at the control center of the body.
In the most exact way you can say that, yes, it is. Not only is it the center for regulating normal body functions, such as like being able to control urination and defecation to respiratory rates, but it also controls everything from the way a person's able to process information. A lot of times they can't process new information. Their food preferences can change. Their hygiene habits can change. Their ways of interacting with the world can be 180 degrees from where they started, which creates challenges that I can't even give advice on how to navigate.
Right. Because you signed up to have a relationship and to live with one person, and it's like a spaceship came and dropped a completely different person into the person that you love. When somebody has these focal symptoms, or even if it's something more sustained, bigger, and it's not the same version of reality that you have, what do you do with it?
I think you just have to assess quickly and decide if it's a safety issue or not. Nearly all patients who've been diagnosed with glioblastoma have a high risk of seizures, and so that also makes them not safe to operate machinery and heavy.
All right, so now we have a sense that all these different symptoms that people can have with the same tumor, they're happening because perhaps where in the brain the tumor's located, how much damage was caused by treatment, right?
Absolutely.
What healthy tissue had happened to it because of the tumor. And that's great information for people to understand, that some of the sometimes even really odd symptoms that people have they're because of this disease, right?
Absolutely.
Okay.
And those experiences that individuals have and their caregivers have that are specific to that patient are very real, likely due to anatomic and physiologic implications of their cancer and its treatments.
And yet they're so hard and frustrating and sad.
And invisible.
And invisible. Because, if somebody had 2 broken arms and 2 broken legs, they'd be in casts, and everybody'd be like, oh, they wouldn't expect the same things from you if you were in that, right? But with this is invisible, and people can present really well.
They can, but they're struggling.
They are struggling. I mean, how could you not, right? If you
Now we're talking about taking parts out of brain tissue,
burning parts of it.
burning parts of it with radiation, giving toxic drugs. You know, that's what chemotherapy is. Ask your ask the oncologist. And then just trying to provide some swelling relief with like dexamethasone, and trying to control seizures with Keppra is a common seizure medication. Those also can lead to some other side effects, which impact functionality.
That's a lot.
It's a lot. But hopefully this has given you some ideas, some confirmation in terms of a better understanding of what this disease is and how it impacts
And
patients.
how it can be so different.
Absolutely.
Different between people, but even different within an individual. Sometimes even hour to hour.
Absolutely.
Okay. All right, great.
Thank you.
Thank you.
We hope this was helpful.
Yes, we do. If you have any questions or comments, we welcome your emails or however you want to contact us. Send us brain signals. That would work. All right.
All right. Take care.